Good morning. My name is Jay Mabrey. I'm an associate professor of orthopedic surgery here at the University of Texas Health Science Center, and I have the honor of speaking to you this morning about COX-2 specific inhibitors and their relationship to arthritis therapy. If we could switch to the first slides. I'd like to start with an introduction and tell you why it's important that we focus on arthritis care. There's an increasing burden on our healthcare resources because of the increasing numbers of people with arthritis in the United States today. If you look at the prevalence of diagnosed musculoskeletal disorders, you can see that the number of patients approaches several million. In osteoarthritis, 16 million people in the United States, rheumatoid arthritis, 2 million, musculoskeletal soft tissue disease, 50 million individuals, representing 20% of the population. This burden of arthritis will continue to increase over time. If we look at data from Arthritis and Rheumatology from 1998 and Morbidity or Mortality Weekly from 1994, it is anticipated that there will be a 57% increase in the prevalence of arthritis by the year 2020 and a 66% increase in the incidence of arthritis causing activity limitation. The economic impact of conventional nonsteroidals is significant. This is the largest drug class in the world. It's the most prescribed class of drugs in the United States. And in 1995 alone, branded nonsteroidals cost $2.5 billion. That's 1995. But at the same time, $4 billion was spent on managing and preventing nonsteroidal-induced gastropathies. Total nonsteroidal-associated acute GI disorders among persons aged 65 years of age and older is estimated to cost the United States $500 million a year. That's the cost of the associated disorders. And again, those are 1996 figures. When we look at the number of upper GI events related to conventional nonsteroidal use, those patients with inflammatory arthritis have over 51,000 hospitalizations per year, almost 8,000 deaths related to the use of conventional nonsteroidals. Those who use osteoarthritis have 56,000 hospitalizations, almost 9,000 deaths. Total cost, $13,000 per hospitalization, $1.4 billion, almost 17,000 people die from the use of nonsteroidals every year in the United States. The mortality from these events is comparable to the mortality from other more well-known disorders. Deaths from HIV totaled almost 17,000. Deaths from leukemia over 20,000. As a review, prostaglandin synthesis is a result of the manufacturing of prostaglandins from arachidonic acid converted into prostacyclins. Cyclooxygenase 1 and 2 have different effects on the body. Many people refer to COX-1 as the good cyclooxygenase because it relates to renal function, platelet function, and gastric protection. Thus, we would not want to inhibit COX-1. COX-2, on the other hand, responds to inflammatory stimuli and is known in some circles as the bad cyclooxygenase. It leads to inflammation, and this is what leads to gastric ulcers. Well, let's look at the clinical profile of one COX-2 inhibitor, celecoxib or Celebrex. I bring this study up because this has been in the news recently. This is the celecoxib long-term arthritis safety study or class. This study was used to determine whether or not celecoxib was associated with a lower incidence of ulcers and other adverse effects. It was a standard design, randomized, double-blind, included osteoarthritis and rheumatoid arthritis patients. They studied celecoxib, diclofenac, and ibuprofen. Sample size was extensive, 4,000 patients with celecoxib, 2,000 patients each with diclofenac and ibuprofen. Basically, the ulcer complication and symptomatic ulcer rates were significantly lower for those patients taking celecoxib compared to those taking conventional non-steroidals. The other most popular COX-2 inhibitor is rofecoxib, or Vioxx. They conducted their own study known as the Vioxx Gastrointestinal Outcomes Research, or VIGOR. This study also was randomized, included only rheumatoid arthritis patients, and they compared their medication with naproxen. Low-dose aspirin patients were excluded. Again, 8,000 patients in the study, 4,000 with Vioxx, 4,000 with naproxen. It's no surprise then that the VIGOR study also confirmed that upper GI events in this patient population were significantly reduced with the use of Vioxx compared with the use of naproxen. In comparing the study designs, the Celebrex study used both osteoarthritis and rheumatoid arthritis patients compared with just RA patients in the VIGOR study. The drugs were slightly different. Low-dose aspirin was allowed in the class study but not allowed in the VIGOR study. But in conclusion, the ulcer complication rates were reduced with both of these COX-2 specific inhibitors as compared to conventional non-steroidal anti-inflammatory medications. The real difference comes from the cardiovascular effects. And this relates to the importance of systolic blood pressure. An increase in systolic blood pressure is an independent and powerful cardiovascular disease risk factor. Coronary heart disease death rates are linearly related to systolic blood pressure at all levels, regardless of the diastolic blood pressure. In the systolic hypertension in the elderly program, or SHEP, a reduction of systolic blood pressure by 14 millimeters of mercury reduced MI by 27%, reduced congestive heart failure by 55%, reduced strokes by 37%. Of important note is that osteoarthritis and hypertension are overlapping diseases in the elderly. They will be treated for both diseases at the same time, but sometimes with different physicians. If we look at the effects of systolic blood pressure in these two studies, the class, which was Celebrex, the VIGOR, which was Vioxx, there really was no effect in the class study, and these are the non-aspirin users. There was no effect on systolic blood pressure with Celebrex compared to non-steroidals. If you look at the VIGOR study, though, there was a mean change of approximately 4.5 millimeters of mercury over the entire group of patients studied. This is an average. This means that many of those patients had a much higher increase in their systolic blood pressure. It's no surprise then that one would see an increase in the incidence of adverse effects related to this increase in systolic blood pressure. Again, looking at the class study and looking at only those non-aspirin users, the difference between the crude incidence of adverse events between Celebrex and other non-steroidals was not significant. In contrast, with the VIGOR study, there was a significant increase in adverse events compared to naproxen. If we look at myocardial infarctions, again, with the non-aspirin users, there was no significant difference between Celebrex and other nonsteroidals. If we look at the Vigor study, there was an effect, significant effect compared to naproxen. And finally, if we look at all reported thrombotic cardiovascular adverse events, in the class study, no difference. In the Vigor study, a significant difference. As you plot these out over time, the three lower graphs represent Celebrex, nonsteroidals in the class study, and the naproxen in the Vigor study. The upper orange curve represents the cumulative total of the adverse events from the rofecoxib. If we look at the incidence of peripheral edema with celecoxib, again, no significant difference between celecoxib and other nonsteroidals. If we look at the incidence of lower extremity edema in the rofecoxib trials, there is a difference between rofecoxib and the other nonsteroidals. And this was most strongly seen in the higher doses of 50 milligrams per day. Well, you might say that these two studies are mutually exclusive. They have different patient populations, they have slightly different protocols. What happens when you compare the two COX-2 inhibitors? This study was conducted by Dr. Welton and his colleagues and was reported in the American Journal of Therapeutics last year. And this was a randomized controlled trial of celecoxib and rofecoxib in older hypertensive osteoarthritis patients, the very patients that I mentioned earlier in this talk. This was a 6-week trial comparing the incidence of clinically significant renal events, hypertension, and other issues. Keep in mind that both the class study for celecoxib and the Vigor study for rofecoxib were not designed initially to look at hypertension and adverse events. These were ancillary findings. The Welton study, on the other hand, was designed specifically to look at these events. The study design was rather straightforward. Hypertensive osteoarthritis patients were allowed to not take their medications for some time to clean out their systems. They started the study drug, which was either celecoxib 200 milligrams a day or rofecoxib 25 milligrams a day. And blood pressure and edema were measured at the start, week 1, week 2, and week 6. Bottom line, in edema, there was a significant increase in edema with rofecoxib over celecoxib. There was also a significant difference in systolic blood pressure elevations of more than 20 millimeters between celecoxib and rofecoxib. Study findings and conclusions basically say that compared with Celebrex at 200 milligrams a day, which is the standard dose, versus Vioxx 25 milligrams a day, which is a standard dose, there was a significant increase in mean systolic blood pressure and in peripheral edema. This then led the Food and Drug Administration to ask the manufacturers to change their labeling. And now it had to indicate that it would be linked to high blood pressure and a small but troubling increase in the risk of heart attacks. Off of the AP wire, Vioxx can advertise that it is gentler to the stomach than an older competitor and that it relieves the pain of rheumatoid arthritis in addition to the more common osteoarthritis. But no one knows yet if there's a real problem, but it's an area of concern that's important enough to raise a flag for doctors to think about. This is Dr. Lawrence Goldkind, and he's the FDA's Chief of Anti-Inflammatory Drugs. So now we have revised rofecoxib labeling indicating precautions and stating that the risk of developing a serious cardiovascular thrombotic event is significantly higher, particularly in patients treated with Vioxx 50 milligrams once a day. Well, what's the current status of the these anti-inflammatories in the United States? In 2001, Celebrex sold $2.4 billion worth of prescriptions. Vioxx sold $2.1 billion. Mobic, or meloxicam, was approved in 2000 but has not really taken off. Celecoxib, another one of the coxib, was withdrawn pending further studies. And then valdecoxib, which one could list as one of the second generation COX-2 inhibitors, was introduced just in April of this year. So I'd like to take a couple of minutes to talk to you about Bextra. This is valdecoxib. It comes in both 10 and 20 milligram tablets. It's anti-inflammatory, analgesic, antipyretic, and the dosing schedule is rather simple. 10 milligrams a day for osteoarthritis, 10 milligrams a day for rheumatoid arthritis, and 20 milligrams a day for 20 milligrams twice a day for primary dysmenorrhea. So if you want to remember the dosing schedule, it's 10-10-2-20. And you can also make your phone calls with that as well. There are no antiplatelet effects. One has to be careful when using it in patients with Coumadin. There may be a slight effect on the INR. You just have to keep an eye on it. When we look at the pharmacokinetics compared to the other COX-2 inhibitors, Tmax is 2¼ hours with Bextra. Terminal half-life is 8 hours, so it's slightly less than Celebrex. When we look at its effects in osteoarthritis, basically in osteoarthritis of the hip, 10 milligrams a day of Bextra is equivalent to 500 milligrams twice a day of naproxen, and it's both are significantly better than placebo. If we look at it in osteoarthritis of the knee, again, both 10 and 20 milligrams a day are equivalent to naproxen, which all three are significantly better than placebo. When we look at the patient's assessment of osteoarthritic pain, and the lower the, the lower the level, the better off you are. You can see that valdecoxib and naproxen are essentially equivalent even out to week 12. And again, with knee osteoarthritis, they're almost identical with naproxen. So if we look at treatment of adult rheumatoid arthritis, again using valdecoxib, look at a study involving over 3,000 patients, and patients who were using disease-modifying anti-rheumatic drugs were also included in these studies. We measured them against the American College of Rheumatology 20 responder index. So patients had to have a 20% improvement in either the number of tender and painful joints, the number of swollen joints, and in 3 or more of the following conditions, which included the physician's global assessment, the patient's global assessment, the patient's assessment of arthritis pain, the disability index, and also C-reactive protein. When you look at the ACR20 responder index at week 12, again, Bextra was equivalent to naproxen and significantly different than placebo. When we look at GI safety, Bextra is listed on the left and is essentially equivalent to the effects one sees from placebo, and it's significantly better than both Motrin, diclofenac, and naproxen. And these were in osteoarthritic patients with endoscopic ulcers. For renal safety, valdecoxib is the light blue on the left. There is a slight increase in hypertension. There is a slight increase in peripheral edema, but both of these effects are essentially equivalent to what one would see with naproxen. So in comparing these 3 COX-2 inhibitors, I would point to the top boxes, which really give you an indication of how they differ. And this is their affinity for the COX-2 active site. And you can construct a ratio of the affinity for the drug for the site based on laboratory assays. So the higher the ratio of COX-2 to COX-1, then the higher the affinity for the medication for the COX-2 binding site, and thus the higher your ability to block the COX-2 effects. If you look at celecoxib, that ratio is 375. If you look at rofecoxib, it is significantly greater with a ratio of 1,000. But then if you look at valdecoxib, that ratio is 28,000. It's almost exclusively binding the COX-2 site. This is a slide on the metabolism of valdecoxib. It gets broken down by the P450 pathway, and then it's excreted in the feces and in the urine, but mainly in the urine. Platelet aggregation, it really has no significant effect and is equivalent to placebo. Incidence of gastroduodenal ulcers, no different from placebo. So in a sense, we're looking at a medication that's equivalent to Celebrex in its GI effects. When we look at the incidence of ulcer complications, significantly less than other nonsteroidals. And if we look at time-specific pain intensity differences with valdecoxib being the white line at the top, it's significantly different from placebo, even 16 hours out from surgery. Time to onset of analgesia, the valdecoxib is the purple line at the top. It's almost equivalent to that of rofecoxib at 50 milligrams, and both are significantly better than placebo. And then if you look at the pain intensity differences between onset and 2 hours, again, Bextra and Vioxx are pretty much equivalent, and both are significantly better than placebo. Well, I'd like to finish up this talk with a discussion on some data that literally has just come out in the major literature, and that is the relationship of the COX-2 site with fracture healing. This is information that has been available at some of the Orthopedic Research Society meetings for the last year or so, but this is the first published paper in a major journal. This was written by Drs. Simon, Managrasso, and O'Connor. It appears in this month's issue of the Journal of Bone and Mineral Research. For those of you not familiar with that journal, it is essentially the Bible of bone and mineral research for the entire world. I'll give you the reference in case you want to look it up. It's volume 17, number 6 from this year, and it's entitled Cyclooxygenase 2 Function is Essential for Bone Fracture Healing. The investigators used a rat fracture model. This was no small study. They used both radiographic, histologic, and mechanical testing to look at the effects of COX-2 on fracture healing. They treated their rats with COX-2 selective nonsteroidals, and these two were Celebrex and Vioxx. In summary, fracture healing failed in those rats treated with COX-2s. Not just inhibited, but it failed. In an additional study, they treated rats with indomethacin, which is not that COX-2 selective, but is a very strong anti-inflammatory, and the indomethacin or indocin-treated rats healed slower than normal, but they did heal. Keep in mind that these rats were given a constant diet of either Vioxx or Celebrex. and that the dosing schedule, although it was somewhat similar to what one might see in humans, was on a constant basis throughout the entire fracture healing period. So, is it just a drug-related phenomenon? Is it just these medications that cause a problem? The authors went one step further, and that's why this is such a strong study. They looked at what are called COX-1 null and COX-2 null mice. Basically, you can breed mice that do not have COX-1 or do not have COX-2 or cyclooxygenase 2. They used the same fracture model, and they noticed that the COX-1 null mice, those mice that did not have cyclooxygenase 1, healed normally after an experimentally induced fracture. They looked at the COX-2 null mice and noticed that these mice produced only a slight periosteal callus. Their conclusion then was that COX-2 was responsible for fracture healing. Interestingly enough, the COX-2 null mice developed normally, developed bone, even though they had no cyclooxygenase 2. So one can say that the cyclooxygenase 2 is not necessarily that important for bone development and bone growth, but it specifically relates to fracture healing in bone. In an editorial that followed that paper, Tom Einhorn, who's probably one of the smartest orthopedic surgeons in the United States, and I know that sounds like an oxymoron, smart orthopedic surgeon, but he's an MD, PhD, and does extensive work with bone and mineral research, reported in his editorial, or concluded in his editorial, and I quote, "It would seem that a prudent approach toward the management of patients is to temporarily avoid or discontinue the use of both nonsteroidals and the coxibs during a period of bone healing." Basically what this says is if you have a patient who has a broken ankle, a broken femur, who's had spine surgery and is counting on a spinal fusion, that one should stay away from not only Celebrex, Vioxx, and Bextra, but one should probably stay away from Indocin, Naproxen, and Motrin as well. And in those patients, at least in my practice, I would start to use Vicodin, Tylenol, or Ultram, or any other type of non-steroidal medication. So in summary, as Evel Knievel says, everything in moderation is okay, except for wild turkey. So I know I kind of ran through that a little fast, but I'd be happy to take questions. Can we take questions from the peripheral sites or just here in the audience? Audience, I'm here. Happy to answer your questions. How do I use these medications in my practice? I like to use the, I have a practice that is pretty much centered around osteoarthritis and rheumatoid arthritis, and I use either Celebrex or Bextra in my practice. I don't see that many fractures, but given this latest data, I think we'll be switching any of those patients over to a Vicodin or Tylenol or something during the fracture healing period. Once the fracture healing period has occurred, and once we've established union, then I think it's reasonable to go back to any of the nonsteroidals for pain relief. Some of our patients have fractures around joints. It takes anywhere from 6 to 8 weeks for those to heal substantially, and they will develop a traumatic osteoarthritis after that. And I think it's reasonable to use the COX-2s in the treatment of the pain associated with that arthritis, but that one would probably want to avoid the COX-2s during the healing period. Also probably avoid the use of COX-2s in patients who have total joint replacements using ingrowth prostheses, uncemented or porous ingrowth prostheses, because that technique depends on a fracture healing model. The bone has to grow into the component in order for it to remain stable, and you need about 6 to 8 weeks for that to occur. Other questions? Both. I have a substantial referral practice from rheumatologists here in town, and especially in the Valley, but I also see patients de novo. Most of my patients with rheumatoid arthritis are referred to me because they have been treated by rheumatologists for an extended period of time. So those are mainly referrals. And then my patients with osteoarthritis, some are referred from primary care physicians, but many others come in because they've read something on the internet and they figure it's time for their artificial knee or their artificial hip. So it comes from both. The diagnosis of osteoarthritis, by the way, is pretty straightforward. We look at their function, we look at the alignment of the joint, we look for osteophytes, we look for joint space narrowing, we look for subchondral sclerosis or increased bone density around the joint. With rheumatoid arthritis, it's a little bit harder, especially in the earlier stages. But in rheumatoid arthritis, the diagnosis would center around the number of swollen joints the patient has in the morning, whether or not they have stiffness in the morning. It also depends upon the appearance of the radiographs, which usually show osteopenia as opposed to sclerosis. And interestingly enough, in rheumatoid arthritis, one does not see the development of osteophytes or extra bone around the joint as one would see with osteoarthritis. It's only after the rheumatoid arthritis is burned out that we start to see the osteophytes, and we start to see basically a post-RA type of arthritis. And then, of course, with rheumatoid arthritis, one would proceed with a chemical workup as well, which would be anti-nuclear antibody and rheumatoid factor, as well as a sedimentation rate, C-reactive protein. And that gives us a basis for establishing that diagnosis.
Questions between the celecoxib and the relocated, which one you prefer to choose?
I prefer to use the celecoxib over rofecoxib, primarily because my patient population is older. Many of them do have hypertension, and I'm trying to avoid that increase in blood pressure as well as increase in peripheral edema. I've had some patients come to me who have been on rofecoxib, and they complain that their feet swell or they feel short of breath. These are older patients, and they are on antihypertensives. I'm also the division chief of orthopedics over at the Veterans Hospital, and the vast majority of our patient population has not one but several medical problems that are being treated concurrently. And for the most part, if a patient is on an antihypertensive medication, I just go straight for celecoxib as opposed to rofecoxib, at least to try and avoid a slight increase in risk.
So for the rofecoxib, you prefer use for the younger people or less?
I think for the younger patients that any of the three coxibs out there is going to work for them. There's some data, or some people would suggest that rofecoxib tends to have more of a pain relieving effect, but that it really hasn't been compared. Well, in comparison with Vioxx, it's pretty much equivalent, as I've shown in some of the later slides. So my tendency in my younger patients would be to go with Bextra for pain relief from sprains and strains, but to stay away from any of the COX-2s in patients who have a fracture or who have had, let's say, an anterior cruciate ligament reconstruction where they may be dependent upon bony healing. So I'd go with something other than other than the COX-2s. Interestingly enough, in the sports medicine field, and I'm sure this is going to start to come out pretty soon now that this study out of Journal of Bone and Mineral Research has come out, they like to use intravenous Toradol right around the time of operation. And I think people will start to back off from that and start using some other analgesic, at least during the first 6 weeks or so.
If a person has had an allergic reaction to one of these drugs, do you assume they're going to be allergic to the entire family, or are there other drugs they could take?
No, I don't assume that they're going to be sensitive to it. There are some package warnings on Celebrex. Patients who may be sensitive to sulfonamides, because it does have a sulfonamide group, those patients may experience a reaction. In those cases, we let them, if it's a minor reaction to the sulfa drugs, I'll give them a sample of the Celebrex and see if that works for them. If it doesn't, then we can try Vioxx or Bextra. But no, I haven't seen any cross reactivity. If they do have a reaction, or if they are sensitive to it, it may be more from the cyclooxygenase inhibiting effect. And I would be very careful in using the COX-2s in patients who have established renal disease. So I see, I'm very aware of that, especially in my patients with renal transplants. And you might say, well, what's an orthopedic surgeon doing with renal transplants? But in order to prevent rejection, the transplant surgeons and the nephrologists dose them with steroids, or have in the past. And that leads to avascular necrosis of the femoral heads, and so I end up doing total hips on those people. So in my kidney patients and my renal patients, I'm quite aware of that. And I'll go with something, with a mild narcotic or Ultram. Other questions on arthritis?
Not a question or a comment. I find this video is going to be just so helpful to the rural clinics who do not have the advantage of coming in or attending various conferences. When we send this out to the Texas Association of Community Health Centers, I feel like this is going to be a boon to them.
Well, I think it's a great way of kind of bringing some of the latest information to them. This article in Journal of Bone and Mineral Research, that's not really on everyone's reading list, and I have to admit, my attention was called to it because I saw it in the newspaper, and I recognized Tom Einhorn's name because I know him personally, and he's when Tom Einhorn says something like that, then you really have to listen. But I would emphasize, at least in this effect that one sees with the COX-2s, that its overall effect on the orthopedic, at least the orthopedic community, is going to be small because the vast majority of our patients are not healing fractures and not just getting over a total joint. It's usually long-term follow-up, that sort of thing. So there's a small group of patients that one has to be careful with, and in the rest of them, one can proceed as you have before. So I think the message to the rural clinics and the primary care physicians is treat the COX-2s as you have before, but if you've if you have a grandmother with a distal radius fracture that you're treating in a cast, then you might want to think of something else for her analgesia than the COX-2s, at least while that fracture heals, and that's for about 6 weeks or so. I know that many older people try to avoid the narcotics because it does have a stronger effect on them, and what I tell my patients is I've never ever seen anyone become addicted to narcotics as long as they've had pain. It's when you start taking the narcotics and you don't have pain that you have a problem. But if as long as you have pain, you won't run into that. Other questions? comments? Well, I really appreciate the opportunity to present this material, and I would just suggest to everyone who's viewing the tape, if you have other questions about arthritis, about the cyclooxygenase 2 inhibitors, or any of the topics that I've discussed today, please feel free to contact me at the Health Science Center, and I know that the GRECC? Wow, I did that right. GRECC can certainly direct your comments towards me, and they can even provide you with an email address as well.